I love this title, Leaps and Bounds for Leaks and Bulges. And we're very fortunate today to have our speaker, Dr. Savitha Krishnon. Dr. Krishnan went to medical school at the University of Michigan, and then she did her internship and residency at George Washington University School of Medicine. She is certified as American Board of Obstetrics and Gynecology, and she has a variety of different specialty areas: minimally invasive gynecology, incontinence, urodynamics, and pelvic prolapse. Now, Dr. Krishnan will be speaking for 20 minutes, and then we'll have 5 minutes for question and answers. And then for those of you who would like to speak individually with Dr. Krishnan, she'll be right through those doors at the Ask an Expert table. And that will be true for each and every one of our presenters. We'll have some alone time if some folks would like to go back and ask some individual questions. So without further ado, Dr. Krishnan.
Thank you. Mic's on? Can you hear me? Yeah? So my name is Savitha Krishnon, and I just joined actually the El Camino Mountain View staff in October. And this is a topic that's really near and dear to my heart. For the last 14, 15 years, all I've been doing is, or actually really focusing on, is pelvic floor prolapse and incontinence. And one of my main interests is actually education and getting information out to getting information out to women so that they can make informed decisions as to what their diagnosis is, what effective treatments are, and what quality of life improvements we can offer to patients. So this is just a cute commercial or a cute ad as to how prevalent this disorder is. So if you look at the number of women that are actually affected by pelvic organ prolapse or incontinence, it's staggering. And what happens is that a lot of women actually don't know about the effective treatment options that are there for pelvic organ prolapse and incontinence. So what I'd like to talk about today is the 3 common types of bladder leakage. And the reason why I want to differentiate them out is that each of these different entities has a completely different management strategy. So it's really important to kind of identify what type of urinary incontinence you have. And then also I'm going to touch on pelvic organ prolapse. But there's so much in this field of pelvic organ prolapse that now we have great evidence-based data. I mean, it's actually become a field just in the last year. So there are large studies of randomized controlled studies of many women that show what effective treatments are, what side effects are. So just, again, really a plug to go out there and become informed. So this is just a slide, and this basically talks about the 2 forms of incontinence. So we have the woman on the left who basically says achoo and has a little bit of leakage of urine. That describes more of a stress incontinence situation. So when you cough or sneeze or exercise, there's a sudden spurt of urine loss. And then we have the woman on the right that's kind of running to the restroom, the woman that knows where all the restrooms are, waking frequently up in the middle of the night. That's more of an urgency situation. And I'll kind of show you what the treatment options are for this also. So urinary incontinence is essentially the loss of bladder control or the involuntary loss of urine. And we know that the prevalence of urinary incontinence, if you include stress incontinence, urge incontinence, and a mixture of these symptoms that a lot of women will have, about 30-35% of women will have some type of urinary incontinence. Yet less than 50% of women actually discuss this with their healthcare provider. And there's a lot of different factors that go into that lack of discussion with their healthcare provider. One is they may be embarrassed about their situation, right, and not want to bring it up. And this is particularly true for fecal incontinence or loss of stool. And there is great, or at least effective treatment out there for fecal incontinence also. But they may be unaware that their condition is treatable, right? I mean, if you look at the history of surgery for incontinence, there's over 100 procedures in the last basically 25 years that have been developed for incontinence. And that kind of makes you think about how effective are these procedures really. But now there are actually procedures that we have 10-year data on that are effective. So they're equally effective at 3 months as out at 10 years. And so we've got, again, large bodies of evidence that show that we've got a good track record with a lot of these procedures. They may think that their symptoms are due to aging. I'm originally from India, and I travel a lot in Asia and India, and I see so many women suffering from incontinence and pelvic organ prolapse, and they're basically racking it up to it's their age. But there are impacts of age on the pelvic floor and incontinence. But these treatments still work for older women, and they're minimally invasive enough that even if you have other medical conditions, it's a lot of times either physical floor therapy or an outpatient procedure that really improves the quality of life for a woman. So when we talk about the three forms of incontinence, these are the three. There's urge, which is the sudden, strong need to urinate due to bladder muscle spasms or contractions. There's stress incontinence, which is an involuntary loss of urine that occurs during physical activity, such as coughing, sneezing, laughing, or exercise. A lot of ways to differentiate this is stress is usually a daytime kind of activity, when a woman is active, jumping, coughing, trying to be active with her kids. Urge tends to be a daytime activity, but more so a nighttime activity, that they're running frequently to the restroom at night. Urge incontinence episodes tend to be large losses of urine, and which is very disturbing to a woman because it's unpredictable, and it's large losses because the entire dome of the bladder is contracting and dumping out all that urine. Versus stress incontinence are small spurts of urine that occur with activity. And then we've got a mixture of these symptoms. So this is kind of the prevalence of urge versus stress versus mix. So 11% of women that have incontinence have probably urge symptoms. 50% of women have stress symptoms. And then we've got about 30-35% that are kind of in a mixed picture. And again, when you talk about incontinence symptoms, you really want to kind of make a correct diagnosis because it's going to lead the correct management. So for urge incontinence, this is described as patients that they just went to the restroom and they feel like they get off the commode and they need to go sit back down on the commode and go again. And treatment options for this is we've got great behavioral therapy treatment options. So actually El Camino Hospital, since I joined staff, I've actually been working with them. Their pelvic floor, physical floor therapy can actually help with urge suppression techniques and kind of an advanced Kegel exercise and directed physical floor therapy. There are dietary changes. So caffeine, we know, impacts urinary urgency significantly if you drink more than 2 cups of caffeine a day or more than 240 milligrams of caffeine a day. Alcohol impacts urgency. Bringing in a voiding log and just looking at what you're drinking and when you're drinking it can actually help impact urinary urgency. Bladder retraining, to simply kind of directed or direction as to how to space out intervals and how to retrain your bladder not to contract as frequently helps. Biofeedback and electrical stimulation helps, and then we've got some newer medications out that have less side effects. So if you've been on previous medications and it hasn't helped for urgency, there are newer FDA-approved medications that are actually more specific to the bladder with less side effects in terms of dry mouth and constipation or sedation that are effective. And then there are some surgical options, but surgical options are typically reserved for stress incontinence. Stress incontinence is the loss of urine with coughing, sneezing, exercise, that sudden spurt of urine that occurs with an increased pressure or abdominal pressure. And this is really important to differentiate out because this is more of an anatomic problem, right? So this is more support underneath the neck of the bladder. And so the treatment options for stress incontinence, so these are risk factors for stress incontinence. We know that as you age, the pelvic floor tends to sag a little bit and we have less support underneath the neck of the bladder. We know that pregnancy, particularly vaginal birth, increases the prevalence of stress urinary incontinence. We know that operative deliveries, forceps deliveries, vacuum deliveries also increase the incidence of stress incontinence. And I'm going to show you, actually if I can switch over to, let's see, switch over here. Or actually I'll keep going and then I'll switch over to the other one later. I'll switch over later. So if we look at anatomic changes for stress incontinence, we have the front wall of the vagina that really supports the mid-urethra or the neck of the bladder. So here's the bladder, here's the neck of the bladder, here's the uterus, cervix, vagina, and the rectum. And we've got that front wall supporting the neck of the bladder. So what happens is when you cough or sneeze or exercise, this front wall is supporting the neck of the bladder. So actually, if I could switch over, Brian, over to the other one, I have kind of a dynamic model of what happens with stress incontinence. So the treatment options for stress incontinence are really aimed at support of this front neck of the bladder. So if you go in for physical floor therapy, the pelvic floor physical therapist is going to actually help with strengthening that front wall of the bladder. So we've got treatment options for stress incontinence. So we've got non-surgical treatment options, which is pelvic floor muscle training. And they've looked at women that have actually been highly motivated to continue their pelvic floor exercises, and they do well. Mild to moderate stress incontinence patients or patients with a little bit of leakage with coughing or sneezing do well with physical floor therapy. The only problem is you have to have a motivated patient, and you have to have realistic expectations that they're going to continue their pelvic floor exercises after the intensive treatment has stopped. And those women actually do well with stress incontinence. We have bladder retraining. We have pessaries, which are small rubber or latex devices that basically go underneath the mid-urethra, and they basically give a little bit of additional support underneath the neck of the bladder. So there are great conservative options for stress incontinence. And then we've got surgical options, and our surgical options are outpatient procedures now. So they basically involve general anesthesia for about 30 minutes, 45 minutes. It's an outpatient procedure. It's a vaginal surgery with high success rates, 85 to 90% improvement in stress urinary incontinence symptoms. And that's where we've got procedures that actually last 10 years out. So if at 6 weeks you're continent with a procedure for stress incontinence, more than likely at 10 years you're still going to be dry from a stress incontinence perspective. So great satisfaction rates, because I have so many women that come in and ask me, well, my grandmother had a procedure done, she was in the hospital for 4 days, and now it doesn't work anymore. So there are great treatments out that are minimally invasive, outpatient procedures, no hospitalization, great recovery rates, vaginal surgery that last over 10 to 15 years of data. So stress incontinence is very common, and there are a lot of barriers to basically getting medical attention for this, but there are great effective treatments for urinary urgency as well as stress incontinence. So again, just a plug, go talk to your doctor, go talk to your primary care doc or your OBGYN or a urogynecologist or a urologist and ask what the options are, because this is really a quality of life improver. And then I also wanted to touch on pelvic organ prolapse, because there is a lot of women that have symptomatic pelvic organ prolapse. And pelvic organ prolapse is essentially the pelvic floor that's not very well supported. So if you look at the pelvic floor, the bladder, and I have a couple of pictures sort of towards the end, the bladder rests on the front wall of the vagina, and the rectum rests on the back wall of the vagina. And pelvic organ prolapse is when tissues that hold the pelvic organs become weak or stretched. And again, 45 to 75% of women are affected by pelvic organ prolapse. But what we've realized, as this evidence of literature is developing in this field, that prolapse, that we termed prolapse or stage 1 or stage 2 prolapse, is actually normal anatomy for a lot of women that have had vaginal deliveries. So if you have a little bit of prolapse that a gynecologist or a primary care doc tells you about, as long as you're not symptomatic from it, and I'll tell you what the common symptoms are that you may want to approach medical attention, you don't need to do anything about it, because it's a common normal finding for a lot of women. And the symptoms that you're looking for is a lot of women will start approaching a doc when they're prolapse or when they see a bulge of tissue, hence my title of the topic, bulges and leaks, but a bulge of tissue comes out of the vagina. Or they'll feel pulling or stretching feeling in the groin area. They may have some pressure, difficulty with bowel movements, because again, that rectum rests on the back of the vagina. Or they may have a slower urinary stream as the bladder starts to prolapse. It kinks off the neck of the bladder, and people may have difficulty with urination or need to get in different positions to urinate, or they may have difficulty or painful sexual intercourse. Common risk factors are very similar to incontinence risk factors: pregnancy, childbirth, menopause, prior surgery, particularly hysterectomy, obesity, aging, and genetics. We've got different forms of prolapse, and I'm going to go through each one of these. But here you can see the anatomy very well. So we've got the uterus, we've got the cervix, we've got the vagina. We've got the bladder, we've got the neck of the bladder, and we've got the rectum. So a cystocele is when that front wall, of the back wall of the bladder pushes on the front wall of the vagina, and you see a tissue bulge. As this happens, as this gets progressively worse, you will see that tissue bulge right here at the opening of the vagina. And what happens is here's the neck of the bladder. So as that tissue bulge gets worse and worse and worse, you get an obstruction of the neck of the bladder, and people have to get into different positions to empty their bladder. We've got a rectocele. So here the rectum is coming down in the back, and if the rectum, the front wall of the rectum pushes on the back wall of the vagina, people have a difficult time emptying their bowels and need to sometimes have a lot of fiber in their diet, or actually even go in manually and reduce that prolapse to be able to empty their bowels. Vaginal prolapse, this is similar to uterine prolapse, but this is basically a depiction of a patient that's had a prior hysterectomy where the top of the vagina is starting to prolapse out of the opening of the vagina, and that compromises the entire support structure in the vagina. So prolapse is really common also. I mean, it's just how symptomatic are you with the prolapse as to whether or not you want to address the prolapse or not. And we've got great evidence-based medicine, again, that tells us what the efficacy of pelvic floor exercises are. So sending someone to a directed pelvic floor physical therapist and going through exercises to strengthen the pelvic floor helps with mild to moderate prolapse. We know that with severe prolapse, not as effective, or at least we've got to set up realistic patient expectations for physical floor therapy. We also know that other treatments for pelvic organ prolapse, we have pessaries. So we've got small round latex devices that can be placed into the vagina and that will support prolapse, that again have very little side effect and can replace the normal anatomy. So if you have a functional problem, you're not emptying your bladder completely and you don't want to go into a surgical procedure, a pessary is a great option. We've got vaginal procedures with good data that replace this anatomical disconnection and actually improve things for patients. And we've got laparoscopic or abdominal procedures that improve things. But right now, most of the treatment for minimally invasive, for prolapse is minimally invasive, either no hospitalization or just an overnight stay. And then, if you want to approach me later, I can speak about fecal incontinence and the prevalence of fecal incontinence. And then there's a lot of information that I can direct you to in terms of studies in regards to pelvic floor physical therapy, pessaries for prolapse and incontinence, and any treatment options for urgency and overactive bladder symptoms. Thanks for your attention. Questions? Yeah.
Have there ever been any studies between the Asian bathrooms and I'll say the United States, but I'm sure Europe does it too. Does it empty the bladder more when you squat?
There haven't been great studies in terms of comparison of Western toilets and Asian toilets in terms of squatting positions. There are some pretty good studies about genetics, though, and prolapse, and that there are particularly more prolapses in certain ethnicities that kind of skew that data a little bit also, but no direct comparison on Western and Asian toilets. It's interesting, though. Yeah. Yeah, so the question is wearing a pessary a cause for recurrent bladder infection? And it depends. So if the pessary is obstructive enough that you're not able to completely empty your bladder and you have some urinary retention with that pessary, it will be a cause for recurrent urinary tract infection. Pessaries, the most common concern with pessaries is a vaginal discharge or a vaginitis or recurrent vaginal infections just from that foreign object that's sitting there. But as long as the pessary is not too tight and is not obstructing the urethra, people typically don't have urinary tract infections. So there are certain pessaries. You're coming to see me next week. Good. Yes?
I have two questions. First one is, do you have any data or finding if women had no childbirth?
if women had no childbirth or C-section have less problem with these symptoms. The second question is, if women had Kegel exercise from the childbirth all the way till now, is there any difference?
Yeah. Great questions. So the first question is if you've not had a vaginal birth and you've only had C-sections or no birth, whether or not there's a difference in prolapse. And actually what the studies show is up until the age of 50-51, there is a difference in prolapse and the stress incontinence. So women that have had prior vaginal births are definitely more likely to have stress incontinence and pelvic organ prolapse, particularly forceps and vacuum deliveries. After the age of 51, the playing field kind of evens out. And it's probably because of the lack of estrogen and that contributing factor to prolapse and stress incontinence. So after the age of 51, that risk factor of vaginal birth or an operative delivery no longer holds. And even women with prior cesarean sections or no prior deliveries actually do have an incidence of prolapse. It's a little bit less than vaginal birth, but it does increase because of that lack of estrogen probably. And then the second question about the Kegels exercises, whether or not you do intensive Kegels exercises after childbirth, whether or not that improves the situation. And there is actually good evidence that shows that it does improve the situation somewhat, but you have to be extremely motivated to really do Kegels exercises religiously and keep up those pelvic floor exercises. But a recent study that was published that showed that peripartum or right after delivery Kegels exercises don't significantly impact long-term incontinence and prolapse. And it's that the problem with that is that when they looked at these women, only 25% of women were actually continuing their pelvic floor exercises long-term. So it takes a really dedicated patient to continue the pelvic floor exercises, which is what the concern is. Yeah, they recently did a study of an arm of a large group of patients in Europe, and they looked at women that were primarily kind of directed towards physical floor therapy and women that were directed towards a procedure for stress urinary incontinence, a minimally invasive stress incontinence procedure, outpatient procedure. And that they showed that the long-term satisfaction rate for the women that were not so motivated with pelvic floor exercises, they tended to cross over to the surgical arm, and they tended to have a little bit better satisfaction with the surgical procedure. But if you're a highly motivated patient, those patients do really well with pelvic floor physical exercises.
Do we have one more question?
Yeah.
We're coming with a mic for you.
You just mentioned about the jumping will cause the urine leak.
Yeah.
And do you still strongly recommend the active woman doing the jump rope?
You know, I honestly feel that you shouldn't limit your activities based on your incontinence, because that's when the quality of life for a woman starts to suffer. So if you have stress urinary incontinence, there's great treatments for it, and I don't think that you should limit your activity because, you know, it's something that's fixable. So that's where I think you should go and approach a medical provider that can actually help you out with the procedure.
Thank you. Please help me in thanking Dr. Krishnan for her speech today.